did they view? When did they chart? The data shows who played what part. Was a note changed? Was an alert displayed? The audit trail knows, while memories can fade. So whether you're a lawyer, nurse, or sleuth, pull up a seat, we'll search for the truth. Every click leaves a clue in the fray. This is what the chart won't say.
Hi everyone, welcome back to What the Chart Won't Say. I'm Syra Pasha. I am an attorney who works as an EMR audit trail expert. Today I'll be going over a real case that I worked on and testified in live at trial as an expert witness. And this case involves a baby who was diagnosed with hypoxic-ischemic encephalopathy, or HIE, shortly after birth. As with all my case study videos, I picked this one because the audit trail contained meaningful evidence that was relevant to the allegations of the case. Or in other words, it contained data that would likely be helpful to the trier of fact, which in most cases is the jury. And I kind of already gave away what happened in this case in the title of this video, but a few hours after the baby was born, one of the nurses went back into the mother's chart and started making changes to the labor record. And those changes included both adding new information and modifying what had been documented hours earlier. And this video is going to explore those changes and why they potentially mattered in the ultimate outcome of this case. I'm also super excited to have a special guest on today's episode, and that is labor and delivery / maternal fetal medicine nurse Savannah June. Savannah is still a clinically active nurse, meaning she sees patients on a weekly basis, and she also works as a legal nurse consultant. And what that means is she works with both plaintiff and defense attorneys and helping them analyze and interpret medical records in obstetric cases. And I first met Savannah when she attended one of my EMR inspection classes back in 2022, so more than 3 years ago, and she's attended every class that I've offered since then, and I've gotten to know her, and her knowledge and her passion for what she does it's really impressive. I like to make this analogy where how I feel about audit trails, where I feel very knowledgeable about it. I could probably do it in my sleep, and I know it so well, and I love what I do. That's how Savannah comes across with obstetrics. So I thought she would be a great guest speaker to share her knowledge and insight about some of the bigger medical topics that come up in this case. So that will be later on in this video. You might have noticed that this video is much longer than my other case study videos. I'm pretty sure by the time I'm done with this video, it's going to be about an hour long. And the reason I made it longer is because of some feedback I received on my other case study videos. When I make these case study videos, my goal or my purpose is to highlight why EMR audit trail evidence is important and relevant as part of a medical malpractice investigation, because it's objective, it was recorded in real time, it really, I feel, helps the trier of fact come to a just result, whether that helps plaintiff or defense, because it's the objective truth, right, of the data, of what happened in the chart. So that's why I make these videos, to educate people about that, because there are certain parts of the country where audit trails are not produced regularly, or there's a lot of resistance in producing them. And I feel like it's 2026, we have so much technology out there, and yet part of medical malpractice case workup is so antiquated and it doesn't make any sense. So I'm hoping that with these videos and the book that I wrote, that I'm helping modernize case workup in medical malpractice cases. So why do I have so much more in this video? Okay, so despite my goal being teaching about EMR audit trails, they matter in the bigger context of the cases, because whether somebody deleted a note or viewed a note, just that phrase or sentence is meaningless without the context, right, of what happened in the case. So I always try to give some information in a medcron, like just enough to like tell you basically what happened and where did the facts of the audit trail like fit into all that, and why it was important. And so some of the feedback I've received in the last few videos are people with like lingering questions about the medicine or who did what and like what happened here. And I like that in the sense is that people are intrigued by the fact patterns, but I just want to say that like there's never going to be enough information in my videos for you to come to a conclusion on the standard of care and causation and judge the cases based on my videos alone. So let's talk about this video. I made all the content that you're seeing in this video based on the medical records themselves and the expert disclosures that were filed by both parties, both sides. And so I did not read any deposition transcripts, and I was not present at trial for any time except for the time that I was on the stand, obviously. So think about that. There's so much more evidence that was presented to the jury that I could ever show you in a 1-hour episode. So it's natural to have questions, but we're not judging the merits of this case in this video. It's intentionally set up that way. I definitely want you to have food for thought. And it's natural to have questions. I'm not saying don't ask questions or wonder, but I'm not putting it out there so we can judge what happened and make a determination of whether or not the standard of care was met. That's not what I'm trying to do with my videos. For example, there is a part in the timeline where the plaintiff and defense disagree about whether the fetal monitoring strips were category 2 or category 3. And if you don't know what those terms mean, don't worry, I do cover that in the video. And if you do know what those terms mean, I just want to let you know that I'm not going to be actually showing you the strips or even mock versions of the strips, because we're not debating whether they were category 2 or category 3 in this video. First of all, I'm not clinically qualified to do that, right? But secondly, that's not the goal of any of my case study videos, is to judge or evaluate standard of care or causation. I just want to give enough context to teach my audit trail portion, but if additional information helps with that, then I'm happy to do so. Okay, and a couple more important points before we get started. First, both sides were represented by very good, skilled, experienced attorneys who have been doing this a very long time. And I bring that up because sometimes people will watch my videos and think that, oh, they forgot to consider this or they didn't do that. But and it's natural to think that because there's a lot to this case and there's only so much I can go over like in an hour. So I would say, instead of thinking that because I didn't mention it that people didn't do it or think of it, I would just consider that maybe I just didn't include it in my video because I had to make a judgment call of what to include for time purposes, right? But they're very good attorneys. And okay, secondly, I did get my client's permission before making this video, but I got permission with a couple of rules in place, and you'll see that as the video goes along. I'm going to respect the restrictions that my client put on me in sharing this. I'm very grateful to my client if they're watching. Thank you. I'm sure they are watching. I hope they are. Okay, and so there's limits to what I can do and share, but it's not going to prevent you from understanding anything in this case, as this for the video to be an educational tool. The next thing I want to talk about is there's a lot of people in this video because there's more than like 15 experts, and then there's the people who are treating the patient, and I use a lot of AI images and videos, and if any of those look like the actual people, if there's any resemblance, that would be pure coincidence. I don't know what anybody looks like. So just wanted to put that out there. I did use, AI pictures and videos and audio. That's just for storytelling purposes so that I can teach better with these visuals. And lastly, I think it's lastly, we'll find out. Please take a moment to like my video and subscribe. Those things go a long way in letting me know that you value this content that I'm making, and it helps the algorithm so that other people can see it too. And then after the video is done, if you want to leave a comment, please do so. I hope I'm not discouraging comments or questions. That's fine. There are limitations to what I can share. So when you get to the end, if you have questions, you can definitely ask them, but I don't know that I can always answer them. I just want to put that out there. And so I think we've covered all the most important things, but if not, when I'm editing the video, you might see like editing version of me come back in and throw something else. Okay, I think we're done for now. Oh, no, we're not. I wanted to go over the order of what we're about to see. Okay, so there's this very long intro. Then we're going to move on to the medical chronology, which is going to be about 10 to 12 minutes long. Then we're going to go over what happened after delivery in terms of like the audit trail. What did the audit trail show about chart modifications after delivery? Then we're going to do the Q&A with Savannah. And then we're going to do expert opinions. And that portion, I already know, is going to be about 30 to 35 minutes, so maybe take a bathroom break before that. And after that, we're going to do like a quick 5-6 minute broad overview of the big ticket items that the jury has to consider, kind of like a synthesis of what we've covered so far and ultimately what the jury is going to be tasked with and the rules that they have, like determining liability, causation, and damages. And then the conclusion of the video. So that's the order, and I do think it'll be about an hour long. We'll see. Okay, so with that, let's get started.
A woman in her 20s arrived at the hospital at 6:49 in the morning. She was full term at 40 weeks and 2 days. This was her first delivery. She reported that her contractions had started around 3 a.m. Her water had broken earlier, around 2 a.m. Her prenatal care had been limited, but otherwise unremarkable.
Just after 7 a.m., the patient was placed on an electronic fetal monitor. An electronic fetal monitoring system is what clinicians use to continuously track the baby's heart rate and the mother's contractions, allowing them to assess how the baby is tolerating labor in real time. The fetal monitoring system had alarms set up for this patient for various measurements and parameters. For example, severe parameters were set at 220 beats per minute for 300 seconds for severe tachycardia and 100 beats per minute for 60 seconds for severe bradycardia. A few minutes later, the midwife performed a sterile vaginal exam. On exam, the cervix was about 2 centimeters dilated and 50% thinned out, and the baby was still relatively high in the pelvis. The baby was positioned head down, but facing upward instead of downward, which can make labor more difficult. The cervix was still positioned toward the back, which also suggests early labor. Thick meconium was present, meaning the baby had passed stool before birth, which can be a sign of stress. Between 8:20 and 8:25 a.m., the labor and delivery nurse entered her interpretations of the patient's fetal monitoring strips for 7:30 a.m. and 8 a.m. For 7:30 a.m., she charted a baseline heart rate of 140 beats per minute, no accelerations, variable decelerations, and moderate variability. The nurse documented that the fetal heart tracing was Category 2. Fetal heart tracings are grouped into 3 categories. Category 1 is generally considered normal. Category 3 is abnormal and may require urgent intervention. Category 2 falls in between. It means the tracing is indeterminate, so the care team has to evaluate the full clinical picture, continue close monitoring, and use clinical judgment to decide whether intervention is needed. The baseline reflects the baby's overall heart rate. Accelerations are brief increases that are generally considered a normal finding. Decelerations are drops in heart rate, and depending on their timing and pattern, they can suggest the baby is experiencing stress. Variability refers to small fluctuations in the heart rate, and it is one of the most important indicators of how well the baby is being oxygenated. For the tracing at 8 a.m., the nurse charted a baseline in the 130s with no accelerations, late decelerations, and moderate variability. These were charted at 8:21 a.m. Late decelerations occur after contractions and can indicate that the baby is not getting enough oxygen during labor. At 8:09 a.m., the midwife messaged the attending obstetrician and reported that the fetal heart tracing was Category 2. There was meconium present, and the patient was still early in labor at 2 centimeters, 50% effaced, and -2 station. The 8:30 a.m. fetal monitoring strips were interpreted by the nurse as follows: a baseline of 135 beats per minute, no accelerations, variable decelerations, and minimal variability. These were entered into the chart at 9 a.m. Minimal variability can be more concerning, as it may reflect reduced oxygenation or a less responsive nervous system. After charting the 8:30 a.m. strip interpretations, the nurse then charted the 9 a.m. interpretation. Her documentation regarding decelerations also included the comment, "See notes." However, no note was entered at this time. At around this time, the patient received an epidural. Over the next several minutes, a series of interventions were performed. The patient was given oxygen, intravenous fluids were started, and at 9:25 a.m. she was positioned for placement of an intrauterine pressure catheter, or IUPC. An IUPC is a device inserted into the uterus to directly measure the strength of contractions. It provides more precise information than external monitors, especially when the external tracing is difficult to interpret. The nurse charted her interpretation of the 9:30 a.m. strip as follows: baseline 135 BPM, minimal variability, absent accelerations, and decelerations. She added the comment "See notes" next to decelerations. Although the nurse charted "See notes," she did not chart any notes at this time. This was the last time the nurse charted her interpretations of the fetal monitoring strips until a few hours after delivery. The patient was repositioned to right lateral. The internal catheter was removed. External monitoring was resumed. Oxygen was restarted. At 9:42 a.m., the midwife sent another message to the obstetrician. She mentioned the fetal monitoring strip was not great. She also reported thick meconium, gave the cervical exam as 3 centimeters, 50% effaced, and -2 station, and said the patient had already been consented. At 9:49 a.m., the nurse documented changing the charting interval from 30 minutes to 15 minutes, meaning the fetal heart monitor strips were to be documented more frequently, at 15-minute intervals. However, no additional interpretations were charted for after 9:30 a.m. until after 2 p.m. At 10:03 a.m., the L&D nurse messaged the obstetrician asking him to come to the patient's room. At 10:11 a.m., the OB was at bedside and the fetal scalp electrode was placed. The fetal monitoring strip for 10:15 a.m. showed absent accelerations, absent decelerations, absent variability, and a baseline of 130 BPM. This is according to documentation entered by the nurse after 2 p.m. and backdated. At 10:26 a.m., the OB formally made the clinical decision to proceed with a cesarean section. By 10:39 a.m., anesthesia was at the bedside and the patient was being transferred to the operating room. At 10:42, fetal monitoring was discontinued. At 11:03, the uterine incision was made. At 11:04, the baby was delivered by cesarean section. At birth, the newborn had poor respiratory effort and low muscle tone. APGAR scores were 4 at 1 minute, 6 at 5 minutes, and 7 at 10 minutes. The APGAR score is a quick assessment used to evaluate a newborn's condition immediately after delivery, including breathing, heart rate, muscle tone, reflexes, and color.
Arterial cord blood gases were obtained immediately after birth. These tests measure the baby's acid-base status and help determine whether there was a period of reduced oxygen. In this case, the arterial cord gas showed a pH of 6.87, a carbon dioxide level of 98, an oxygen level of less than 25, a bicarbonate of less than 17, and a base deficit of -21. Taken together, those results showed severe acidemia, meaning the baby's blood was highly acidic and consistent with significant oxygen deprivation. To understand what these numbers mean, it helps to start with how cord blood circulation works. The placenta delivers oxygen and nutrients to the baby through the umbilical vein, while the two umbilical arteries carry blood and waste products back away from the baby. That is why an umbilical artery blood gas is so important. It reflects the baby's acid-base status at birth. When oxygen transfer is interrupted, the baby's cells can no longer make energy efficiently using oxygen. They switch to a backup process called anaerobic metabolism, which produces lactic acid. At first, the body tries to compensate. It uses chemical buffers, mainly bicarbonate, to neutralize that acid and keep the blood balanced. But if the oxygen problem continues, those buffering reserves get used up. The base deficit helps show how much of that buffering capacity has been consumed. Once the body can no longer keep up, the blood becomes increasingly acidic. That is metabolic acidemia, and it is one of the clearest signs that the baby experienced significant oxygen deprivation. The treating neonatologist interpreted these findings as consistent with an acute compromise shortly before delivery. Once the baby was stabilized and met criteria, cooling therapy was initiated later that day. Also known as therapeutic hypothermia, this treatment lowers the baby's body temperature for a controlled period of time in an effort to reduce ongoing brain injury after a hypoxic-ischemic event. Later, the baby underwent a head ultrasound, which showed signs of brain swelling, including compressed, slit-like ventricles, raising concern for cerebral edema. Several days later, an MRI of the brain was performed, which showed diffuse hypoxic-ischemic injury involving multiple regions of the brain, including deeper structures that are particularly vulnerable to oxygen deprivation. The overall pattern was described as severe. The newborn was admitted to the neonatal intensive care unit for over 2 weeks. During that time, diagnoses included hypoxic respiratory failure, severe perinatal acidosis, hypoxic-ischemic encephalopathy, and seizures, along with concerns for meconium aspiration and possible infection.
The child was diagnosed with cerebral palsy, specifically spastic quadriplegia, as a result of the hypoxic-ischemic encephalopathy sustained at birth. She demonstrates significant global developmental delays, cognitive impairment, and a seizure disorder. Due to the severity of these motor and neurological deficits, she remains non-ambulatory and requires comprehensive, multidisciplinary support for all activities of daily living.
Two EMR systems were used by the defendant hospital. The first was the main inpatient EMR system, used for routine hospital documentation, including notes, orders, and medication records. The second was a separate obstetric system used for fetal monitoring and related labor and delivery documentation. Both audit trails were requested and reviewed to reconstruct an objective timeline of care, documentation, and medical record activity. The audit trail from the fetal monitoring system revealed several important timeline details. Multiple bradycardia and severe bradycardia alarms were triggered. For example, note the alarms at 9:32 a.m. and 9:33 a.m. Based on the system's own parameters, the fetal heart rate was below 110 for at least 1 minute, and then below 100 for another minute, before any acknowledgement was recorded, and by a nurse other than the patient's primary nurse. In many fetal monitoring systems, alarms can be acknowledged from a central location, such as a nursing station, rather than at the bedside. Therefore, an acknowledgement does not necessarily tell you who is physically with the patient or what was done in response. These alarms were triggered just minutes before the midwife messaged the obstetrician that the fetal monitoring strips were not looking great and that the patient had already been consented for a C-section. The audit trail also showed gaps in contraction documentation. The nurse charted contraction details for 7:30 and 8 a.m. at 8:23 a.m., including quantity, duration, and strength. For the 8:30 a.m. period forward, those categories were not completed until approximately 3 hours after the baby had already been delivered. At 9:03 a.m., the nurse documented decelerations, see notes. But no corresponding note was written until about 5 hours later. The nurse then documented the 9:30 a.m. fetal monitoring values at about 9:50 a.m. After that, she stopped charting her interpretation of the fetal monitoring strips. Also at 9:50 a.m., she again documented decelerations, see notes, and backdated the entry to 9:30 a.m. But again, a note was not written until hours later. Starting at about 1:53 p.m., after the patient was transferred to postpartum, the labor and delivery nurse began a 55-minute session of modifying the labor record. Her activity included backdating, deleting earlier real-time assessments and replacing them with more severe descriptions, and adding remarks to explain or justify why the data was missing or difficult to interpret during the critical windows. The nurse initiated the session by creating new entries for contraction data. These entries were backdated with a display time of 8:30 a.m. onwards. Recall that earlier in the morning, the nurse twice entered C notes in the chart without creating any note at that time. Instead, they were entered hours later, after the baby had already been delivered, and backdated to represent earlier clinical timeframes. These notes are explaining why certain key elements of fetal monitoring were not documented contemporaneously. The nurse describes periods during the epidural where the patient was seated or being repositioned, and states that contractions could not be traced during those intervals. She also explains that without a contraction pattern, she could not determine whether changes in the fetal heart rate represented variables, decelerations, or contractions, and that she could not reliably distinguish between those categories. Next, the nurse created new entries for her interpretations of the 10 a.m., 10:15 a.m., and 10:30 a.m. fetal monitoring strips. Recall that prior to 10 a.m., the frequency for documenting strip interpretations was every 30 minutes, and at 9:49 a.m., the nurse changed the frequency to every 15 minutes. However, she did not chart any additional interpretations until hours later. For the 10 a.m. fetal heart rate strips, she documented absent accelerations, variable, late, and recurrent decelerations, and minimal variability. The audit trail shows these were entered around 2:15 p.m. For the 10:15 a.m. strip, she documented absent accelerations, absent decelerations, and minimal variability. About 30 minutes later, she went back to that entry and changed it from minimal to absent variability. Remember from the chronology segment that it was in this general time frame when the obstetrician was at the patient's bedside. In the upcoming expert opinion section, you'll hear that the two sides strongly disagree about whether the fetal monitoring remained Category 2 or had progressed to Category 3. In the final phase of modifications at 2:47 p.m., the nurse deleted her 7:30 a.m. and 8 a.m. assessments of moderate variability and replaced them with minimal variability. This suggests that upon retrospective review, the nurse realized the strip was worse than she initially appreciated, effectively correcting the record to reflect a more compromised fetus after the clinical outcome was known. The audit trail is just one piece of the evidence in this case. It captures activity recorded in real time, showing when information was entered, modified, or viewed within the chart. In that sense, the audit trail functions almost like a silent witness. It does not take sides. It is not created for litigation. And it is not shaped by hindsight. Instead, it offers additional facts that are not visible in the medical record itself. Those facts can help reconstruct a timeline of events. Ultimately, it is up to the jury, as the fact finder, to consider this information alongside all of the other evidence.
Now that we've gone over the MedCron and the audit trail analysis, we are ready for our guest speaker. Hi, Savannah. How are you?
Good. Thanks so much for having me.
Thank you so much for joining us today.
Of course.
Okay, so for my first question, for the viewers who have never been inside a labor and delivery room, how would you explain what fetal monitoring is and why it's done?
It's a great question. So, fetal monitoring is a screening tool that monitors the fetal heart rate and the uterine activity. It's how we keep an eye on how the baby is tolerating the labor. With each contraction, there's a temporary reduction in oxygen flow that goes to the baby. The monitor lets us see the baby's heart rate in real time, which gives us clues about how the baby is tolerating labor. The goals for fetal monitoring are to catch patterns early, intervene appropriately, and keep both mom and baby safe during labor.
So when you're looking at the fetal monitoring strip, what exactly are you looking for?
So during labor, we're looking at the relationship between the contractions and the baby's heart rate. I'm paying close attention to how often the contractions are happening, how long they're lasting, and whether there's enough rest time in between them. Contractions naturally decrease blood flow and oxygen to the baby for short periods, so the baby really needs that time between contractions to recover. If the contractions are too frequent, too long, or that rest period shrinks, then the baby can receive less oxygen overall. What happens then is we may start to see changes in the fetal heart rate, like decreased variability or decelerations.
Okay, so you did mention some terms that maybe some of the viewers are not familiar with. Could you please take a minute to explain what variability and decelerations are, and what they mean in terms of how the baby is doing?
So these are terms to describe what we're actually seeing on the strip. I'm going to keep this very non-medical. So variability is basically how squiggly the baby's heart rate looks. If you look at your smartwatch, your heart rate isn't one flat number. It's 82, 86, 90, back to 84. That natural beat-to-beat movement is variability. So when we see normal amounts, what we call moderate variability, that's one of the best signs that the baby is getting enough oxygen. If those squiggles start to flatten out or disappear, we have to ask why. Sometimes decreased variability is caused by less oxygen flow to the baby. Accelerations are a brief increase in the fetal heart rate. They are a sign that the baby is doing okay. We don't just eyeball them, there's specific measurements that we need to count, but that gets kind of technical. And decelerations, I think that was the other term I mentioned, are drops in the fetal heart rate. So some of them are expected during labor, and others can reflect an interruption in oxygen flow to the baby. It really depends on their timing and pattern. There's 4 main types, and they each have their own different characteristics. When you look at all of that together, variability, accelerations, decelerations, you get a much clearer picture of how well the baby is tolerating labor.
Thank you. Okay, so with my background, like I've been reviewing many medical malpractice cases before I did audit trails. For like 5 years, I was working in claims and I had to review some cases, and part of that was reviewing birth injury records. And so over the years, I see a lot of terminology like reassuring, concerning, categories 1, 2, and 3. Those are the common, terms that I see when reviewing these records. Can you please just help explain what those terms are and how they're used to describe what the strip shows?
So, reassuring and non-reassuring and concerning are kind of vague terms. And in 2008, we went away with those because we want to be talking in the same language. We want to make sure that we're using specific criteria to explain what we're seeing. So we used what's called categories, and there's category 1, 2, and 3. And in simple terms, if you think of it like 3 buckets, okay? Category 1 is normal, and that is strongly predictive that the baby is getting enough oxygen. Category 2 is kind of a gray zone. It's considered indeterminate. It is the biggest bucket because it contains so many different patterns that fall into it. It requires closer monitoring and clinical judgment. And then category 3 is the smallest bucket, but it is abnormal and it signals a high risk for fetal compromise. And this is usually when urgent action is needed. During labor, we see a lot of category 2, which is why interpretation of the fetal monitoring strip really matters so much.
So then, would you say that there are guidelines, like established guidelines, with regard to how to read and interpret these strips?
Yeah, there are standardized definitions, and those were developed by national expert groups, and they were put into place so that we would be describing what we're seeing in one language. We're not going to be using different vague terms. There is objective definitions to what we're looking at. The measurements either meet the definition or they don't. But interpretation goes beyond measurement. The strip shows what's happening, but context kind of guides the response. So even with standardized definitions, there isn't always one clear answer.
One of the terms that comes up a lot in labor and delivery cases, which I'm not sure if you mentioned it, but I don't think we talked about it in detail, is the word interventions. Can you please explain what an intervention is and what it means in the context of labor and delivery?
So interventions are corrective measures for what we're seeing on the fetal monitoring strip. And it's things that the nurses can do to try and help improve the blood flow to baby. And that can include changing positions, giving IV fluid, stopping certain medications, notifying the provider. There's a lot of different interventions that nurses do. And that's something that I'm really paying close attention to when I'm reviewing cases.
So I have had the pleasure of knowing you and having you in my audit trail classes over several years. And since you do work as a legal nurse consultant, can you just share your thoughts about the utility of audit trails? Are they important to you? Have they affected your review of cases, for example?
Yeah, I would definitely say they're important. In most of my cases that I've reviewed, there's usually a gradual change to the fetal heart rate over time. And so the audit trail shows the documentation timeline, and it can help clarify when assessments and interventions were entered and whether entries were contemporaneous or added later. And in some systems where charting occurred at the bedside or at the nurse's station, or whether fetal alarms were silenced or acknowledged. It's objective data that really helps align documentation timing and the clinical picture.
Okay, well, those are all my questions. Thank you so much for taking the time to share your knowledge with my viewers. I really appreciate it.
Of course, thank you so much for having me.
Okay, so now we're ready to move on to the next segment of the video, which is expert opinions. And if you recall from the life cycle of a medical malpractice case, both sides have to disclose experts about standard of care, causation, and damages. That's pretty standard in every medical malpractice case. And how many experts testify or disclose kind of goes along with how complex the case is. So in this case, both sides disclosed, I think, a minimum of 7 experts each. And I have summarized basically all of those opinions. So before we get started, I just want to point out one thing, is that the care at issue in this case took place several years ago, like before 2021. So I bring that up because, you know, sometimes standards change or custom and practice changes with time. So whatever is mentioned in this next section is appropriate for the time period that the care took place. Okay, let's get started.
In this section, we will review the plaintiff's experts. The specialties include obstetrician and maternal fetal medicine specialist, certified nurse midwife, labor and delivery nurse, pediatric neurologist, neuroradiologist, neonatologist, physical medicine and rehabilitation physician, and life care planner. economist and labor economist, and an audit trail expert. We will now go through short summaries of each expert's opinions, along with visual aids to help explain their conclusions.
I am a medical doctor and a board-certified expert in obstetrics, gynecology, and maternal fetal medicine. My professional opinion is that the medical team at this hospital failed to meet the standard of care, leading to irreversible brain injury for the child. The mother's prenatal course was uneventful, and she should have delivered a healthy baby. However, the fetal heart rate began showing signs of hypoxia starting around 9:30 a.m. The clinical circumstances established that the asphyxia likely began around 9:41 a.m. By 9:42 a.m., it was no longer reasonable to watch and wait. A cesarean section should have been ordered immediately. Instead, we see a series of negligent delays and communication failures. Nurses repeatedly silenced bradycardia and severe bradycardia alarms without being at the patient's bedside to address the problem. Furthermore, the main labor and delivery nurse deleted multiple chart entries relating to her interpretations of the fetal heart rate after the birth had already occurred. The labor and delivery nurses and the midwife also failed to comply with the applicable standards of care in their communications with the attending obstetrician, and those failures resulted in an unreasonable delay in delivering the baby. When the obstetrician finally arrived at the bedside at about 10 a.m., the tracing had clearly deteriorated, yet he failed to recognize the emergency or call for an emergent delivery. By 10:15 a.m., the nursing records reflected a Category 3 strip with absent variability and recurrent decelerations. At that point, the baby was at significant risk of suffering irreversible brain damage, beginning after approximately 10:15 a.m., and that brain damage continued with each passing minute, with the most severe brain damage likely occurring closer to the time of birth. Even after a decision was eventually made to operate at 10:26 a.m., it took 37 minutes to make the uterine incision. This violates the 30-minute decision to incision standard of care recommended by the American College of Obstetricians and Gynecologists. Because of these compounding delays, the baby was born with an arterial pH of 6.87 and a base deficit of -21, indicative of severe metabolic acidemia. She suffered acute profound asphyxia and hypoxic-ischemic encephalopathy. Earlier delivery would have avoided the development of severe metabolic acidemia and irreversible brain damage. Had the nursing staff and physicians complied with the standard of care and delivered this baby by 10 a.m., these life-altering injuries would have been prevented. Waiting until 11:04 a.m. to deliver this baby allowed the asphyxia to progress and become more severe, resulting in additional brain damage due to acute profound asphyxia.
I am a certified nurse midwife with experience in managing patients during labor and delivery, including the interpretation of fetal heart rate tracings and the identification of conditions that require timely intervention or expedited delivery. Based on my education, training, and review of the medical records, fetal monitoring strips, and deposition testimony, it is my opinion that the care in this case fell below the applicable standard of care, and that those deviations contributed to a delay in delivery and the resulting injury. In my opinion, the fetal heart rate tracing in this case was concerning early on and continued to deteriorate.
The midwife herself acknowledged that the strip was, quote, not great. She communicated that to the attending physician in a message at approximately 9:42 a.m.
At that point, the standard of care required more than just sending a message. If a timely response is not received, the midwife has a duty to act. That includes following up, escalating the concern, and ensuring that a physician comes to the bedside to evaluate the patient and determine whether expedited delivery is necessary. The tracing at that time showed variable, late, and recurrent decelerations, along with minimal and at times absent variability. Those are not subtle findings. They are signs that the fetus may not be tolerating labor and may not be getting adequate oxygen. The nursing documentation also reflects a failure to recognize these patterns. There are multiple entries indicating that decelerations were not identified and that minimal or absent variability was not appreciated by the nurses involved. By 9:42 a.m. at the latest, the tracing had deteriorated to the point where continuing to wait was no longer appropriate. The patient was still remote from delivery, with thick meconium, and the standard of care required moving toward a prompt cesarean delivery. By approximately 10:15 a.m., the tracing met criteria for a Category 3 pattern, with absent variability and recurrent decelerations. That represents a significant risk of hypoxia and acidemia and requires immediate intervention. There was no fetal heart rate tracing from approximately 10:42 a.m. until delivery at 11:04 a.m. Given the prior deterioration, it's reasonable to conclude that the condition continued to worsen during that time. Based on all of this, it is my opinion, to a reasonable degree of midwifery certainty, that there was a failure to recognize and respond to a deteriorating fetal heart rate tracing, and that this resulted in a delay in delivery that increased the risk of hypoxia, acidemia, and ultimately contributed to the baby's injury.
I am a labor and delivery nurse with more than 20 years of experience practicing in a high-volume academic medical center. I hold a Bachelor of Science in Nursing and maintain advanced national certifications in both inpatient obstetric nursing and electronic fetal monitoring. In addition to my daily clinical practice, I serve as a designated instructor for a leading national organization where I teach intermediate and advanced fetal heart monitoring to other healthcare professionals. My professional opinion, held to a reasonable degree of nursing certainty, is that the nursing staff at this hospital deviated from the standard of care directly contributing to the irreversible brain injury suffered by the child. The responsibilities of a labor and delivery nurse include ongoing assessment of the fetal heart rate tracing, assessment of uterine activity and resting tone, recognition of signs that the fetus may not be tolerating labor, communication of significant findings to the care team, and advocacy for timely intervention when the clinical picture is worsening. The fetal heart rate tracing in this case showed significant abnormal findings. Those findings included variable decelerations, late decelerations, recurrent decelerations, minimal variability, later absent variability, and absent accelerations. In my opinion, these were clinically important findings that required prompt recognition and response. The nursing staff failed to properly recognize and communicate the significance of those findings. The medical record contains multiple nursing notes that, in my opinion, reflect a misinterpretation of the tracing. The standard of care required the nurses to recognize that this was not a tracing that could continue to be observed without decisive action, particularly where the patient remained remote from delivery. By 9:42 a.m., at the latest, the tracing had deteriorated to the point that continued observation was no longer reasonable. At that point, the nurses were required to clearly communicate that deterioration, advocate for expedited delivery, and, if necessary, go up the chain of command. In my opinion, that did not occur. The handling of the fetal monitor alarms also fell below the standard of care. Bradycardia and severe bradycardia alarms were acknowledged by nurses who were not the primary bedside nurse, without documentation showing that the fetal status was being fully assessed and addressed. In my opinion, a nurse should not silence another nurse's alarm without first making sure that the patient is being evaluated and that the underlying problem is being managed. The documentation is also significant. The record reflects that, after the care in question, entries were deleted and changed, including entries modifying prior fetal heart rate assessments. From a nursing standpoint, contemporaneous documentation is important because it reflects what the nurse recognized and when that recognition occurred. By 10:15 a.m., the fetal monitoring strips reflected a Category 3 pattern with absent variability and recurrent decelerations. There is then no fetal heart rate tracing from approximately 10:42 a.m., when the fetal monitoring device was turned off, until delivery at 11:04 a.m. Given the baby's condition at birth and neonatal course, it is reasonable to conclude that the tracing continued to deteriorate during that final period. In summary, the nursing failures in this case involved deficient recognition, deficient communication, and deficient advocacy. In my opinion, those failures contributed to a delay in delivery that exposed the baby to worsening hypoxia, acidemia, and preventable brain injury.
I am a medical doctor who is board certified in pediatrics and psychiatry and neurology with a special qualification in child neurology. In my opinion, to a reasonable degree of medical certainty, this child suffered permanent and irreversible brain damage from hypoxic-ischemic injury caused by partial prolonged asphyxia with a superimposed acute profound or near total asphyxial event at or around the time of birth. I base that opinion on my training, experience, my examination of the child, and my review of the medical records, imaging, laboratory results, and neonatal course. These two injury mechanisms are different but can occur together. Partial prolonged asphyxia involves reduced oxygen and blood flow over a longer period of time, often 30 minutes to an hour, and the injury is cumulative. Acute profound asphyxia is a sudden, severe interruption of blood flow that can cause irreversible brain injury in as little as 10 to 15 minutes. Here, the evidence supports that combined mechanism. The records show abnormal fetal heart rate tracings, severe metabolic acidosis at birth with a pH of 6.87 and significant base deficit, low APGAR scores, and immediate need for resuscitation. The child also developed early clinical signs consistent with hypoxic-ischemic encephalopathy, and the imaging showed a pattern consistent with both partial prolonged and acute profound asphyxia. I also do not see evidence of another cause, such as a genetic condition, infection, metabolic disorder, or developmental abnormality. Based on the medical record, I do not see evidence that irreversible injury had already occurred before approximately 10:15 a.m. The most critical period was the final 30 to 45 minutes before delivery, when the baby was not receiving adequate oxygen and blood flow and developed severe metabolic acidemia. That timing matters because once this injury process begins, it continues to worsen the longer the baby remains in the compromised intrauterine environment. Earlier delivery makes it more likely that irreversible brain damage can be prevented or minimized. In my opinion, if this child had been delivered earlier, more likely than not, she would have been born with a normal brain. Even delivery after approximately 10:15 a.m. but before 11:07 a.m. would have reduced the extent of injury. Taken together, the clinical findings, laboratory data, imaging studies, and neonatal course support that this was an intrapartum hypoxic ischemic injury caused by delayed delivery, resulting in permanent neurological damage.
I am a board-certified neuroradiologist with more than 2 decades of clinical experience interpreting neuroimaging studies, including MRI and ultrasound imaging of the newborn brain. Based on my review of the imaging studies in this case, including the head ultrasound performed shortly after birth and the MRI performed at approximately 7 days of life, it is my opinion that the findings are consistent with a hypoxic ischemic brain injury occurring at or around the time of delivery. The initial head ultrasound, performed at approximately 19 hours of life, showed slit-like ventricles and increased echogenicity of the white matter, which are findings consistent with brain swelling and edema. While ultrasound is a limited tool for precisely timing injury, these findings are consistent with a recent hypoxic event. The MRI performed several days later provides more detailed information. That study demonstrated diffuse abnormalities throughout the brain, including swelling and signal changes affecting both the cortical regions and deeper structures such as the thalami, hippocampi, brainstem, cerebellum, and corpus callosum. In my opinion, this pattern represents a classic mixed injury, consisting of partial prolonged hypoxic ischemic injury with a superimposed acute profound asphyxial event. This type of pattern is well recognized in neuroradiology and reflects both a sustained period of decreased oxygen delivery and a more acute severe interruption of blood flow. Importantly, the distribution of injury, particularly the involvement of the deep gray matter structures, supports the conclusion that a significant acute event occurred close in time to delivery. I also found no imaging evidence of alternative causes for the brain injury. There are no findings to suggest a genetic disorder, infection, metabolic condition, or developmental malformation that would explain the abnormalities seen on imaging. Based on the totality of the imaging and my experience interpreting thousands of similar studies, It is my opinion to a reasonable degree of medical certainty that this child's brain injury was caused by hypoxic-ischemic injury due to partial prolonged asphyxia with a superimposed acute profound event occurring at or near the time of birth.
I am a medical doctor and a board-certified neonatologist with subspecialty certification in neonatal perinatal medicine. I am also an assistant professor, and I have extensive experience diagnosing and treating newborns with hypoxic-ischemic encephalopathy, birth asphyxia, seizures, and metabolic acidosis. My opinion, to a reasonable degree of medical certainty, is that this child suffered a hypoxic-ischemic brain injury caused by asphyxia before delivery, specifically a partial prolonged asphyxial process with a superimposed acute profound event. In this case, there are multiple objective findings that support that conclusion. The fetal heart rate tracing showed minimal and absent variability with decelerations, which are recognized warning signs of fetal hypoxia. The baby was born with severe metabolic acidosis, including a cord arterial pH of 6.87 and a base deficit of -21. At birth, she had depressed APGAR scores, required resuscitation, and then developed hypoxic-ischemic encephalopathy, seizures, and multi-organ dysfunction. The imaging studies also showed a pattern of injury consistent with asphyxia. In my opinion, there is no evidence of another cause for this injury, such as infection, genetic abnormalities, metabolic disorders, or developmental malformations. My opinion is that the asphyxial process began at or about 9:50 a.m. and became more severe until the time of delivery. From that point forward, with each passing minute, the risk of irreversible brain injury increased. The most severe injury likely occurred during the last 30 to 45 minutes before birth. Brain injury from asphyxia is cumulative. The longer the baby remains in that hypoxic environment, the greater the injury becomes. In my opinion, had this baby been delivered sooner, more likely than not, she would have been born with a normal brain and would not have suffered these permanent neurological injuries.
The following is a high-level summary of the plaintiff expert's opinions regarding damages. This position argues that the child has sustained profound permanent injuries that will require lifelong care, support, and resources, resulting in substantial economic and non-economic damages. The economist applies accepted economic principles to estimate the present value of these losses, incorporating factors such as work-life expectancy, wage growth, and long-term care costs. The analysis relies on the life care plan and uses market-based pricing for goods and services to project the cost of care over the child's lifetime. Taken together, these opinions reflect the position that the child will require round-the-clock, lifelong care, and that the resulting damages are substantial due to both the extensive cost of that care and the complete loss of future earning capacity. The plaintiff contends that the child's life expectancy is near normal, provided she receives appropriate medical care and supervision. Based on life tables and medical judgment, the opinion is that she has an additional life expectancy of approximately 77.5 years from the time of trial. This extended life expectancy significantly increases the duration and scope of future care needs. The plaintiff argues that the child's impairments are severe and permanent. As a result of hypoxic-ischemic encephalopathy and resulting cerebral palsy, the child has significant limitations in cognition, communication, mobility, swallowing, strength, and coordination, affecting her ability to perform basic daily activities independently. She is not expected to be employable at any point in her life. The life care planning expert outlines a comprehensive plan of care designed to maintain the child's highest practicable level of functioning and quality of life. This includes ongoing physician care across multiple specialties such as neurology, rehabilitation, and gastroenterology, as well as medications for spasticity and digestion, including interventions such as Botox. The plan also includes continuous assistance with activities of daily living, including feeding, mobility, and personal care. The opinion is that the child will require 24-hour care and supervision for the remainder of her life, along with specialized housing accommodations and transportation. In addition, the plan accounts for ongoing therapy services, including physical, occupational, and speech therapy, as well as durable medical equipment, such as orthotics, mobility devices, and feeding equipment, along with recurring disposable supplies. These recommendations are based on direct evaluation of the child, review of the medical records, and input from her family regarding her daily needs.
We're now going to turn to the defense experts. The defense disclosed experts in the following specialties: obstetrics and maternal fetal medicine, certified nurse midwifery, labor and delivery nursing, placental pathology, neonatology, pediatric neuroradiology, pediatric neurology, financial planning, pediatric rehabilitation medicine, life care planning and case management, life expectancy, economics, and an audit trail expert. We'll go through short summaries of their opinions, along with visual aids where helpful.
I am a medical doctor and a board-certified expert in obstetrics, gynecology, and maternal fetal medicine, and I am also a professor in that field. My professional opinion is that the care provided during this labor and delivery met the applicable standard of care and did not cause the child's injuries. The mother's prenatal course was largely unremarkable, with no clear indication prior to labor that this baby would suffer a severe neurologic injury. During labor, the fetal heart rate tracing showed changes that required attention. However, when reviewed as a whole, it remained a Category 2 tracing, not a Category 3 tracing, throughout the relevant time period. A Category 2 tracing is indeterminate. It requires continued monitoring and clinical judgment, but it does not automatically require immediate delivery. The clinical team appropriately monitored the patient and used standard interventions, including repositioning, oxygen administration, and fluid management. These measures are commonly used to support the fetus during labor. There is no evidence that the tracing reflected a sustained Category 3 emergency requiring an immediate cesarean section at 9:42 a.m. or at any other specific point prior to the decision to deliver. With respect to the alarms, bedside clinical assessment and interpretation of the actual tracing are more reliable than alarm notifications alone. Alarm activity must be interpreted in context, and there is no indication that the care team failed to appropriately assess the patient. From a communication standpoint, the nurses, midwife, and physician functioned appropriately as a team. The midwife communicated with the attending physician, who came to the bedside, evaluated the patient, and participated in decision-making. The clinical decisions were based on the overall condition of the patient, not isolated data points. The timing of the decision to proceed with cesarean delivery was reasonable and consistent with the standard of care. This was not a situation requiring a crash or emergent cesarean section earlier in the course of care. Once the decision was made, the patient was appropriately prepared and transferred to the operating room, and the cesarean delivery was performed in a timely manner. While the baby was born with severe metabolic acidemia and later diagnosed with hypoxic-ischemic encephalopathy, those findings do not establish that the injury was caused by events during this labor and delivery. The medical and imaging evidence is consistent with the possibility that the injury occurred prior to delivery. In summary, the fetal monitoring, clinical decision-making, communication among providers, and timing of delivery were all appropriate and within the standard of care, and there was no deviation that caused or contributed to the child's injuries.
I am a certified nurse midwife with clinical experience in labor and delivery, including the interpretation of fetal heart rate tracings and the management of patients in active labor. Based on my review of the records, including the fetal monitoring strips and clinical documentation, it is my opinion that the care provided met the applicable standard of care. The patient presented with limited prenatal care and was appropriately placed on continuous fetal monitoring. Throughout the course of labor, the fetal heart rate tracing remained Category 2. In my opinion, it did not meet the criteria for Category 3 at any point prior to delivery. The tracing showed periods of both moderate and minimal variability, and while variability decreased over time, it was not absent. I do not find evidence of persistent absent variability with recurrent decelerations or sustained bradycardia that would meet the definition of a Category 3 tracing. The interventions that were implemented, including maternal repositioning, oxygen administration, fluid bolus, and internal monitoring, were appropriate responses to a Category 2 tracing. In my opinion, these measures were timely and consistent with accepted clinical practice. The midwife appropriately communicated with the physician, when the tracing remained Category 2, and the physician evaluated the patient and made the decision to proceed with delivery at an appropriate time. It is also important to recognize that fetal monitoring strips must be interpreted in their entirety and within the clinical context, and that reasonable clinicians may differ in their interpretation of specific features such as variability and decelerations. Based on all of the available information, it is my opinion that the clinical decision-making in this case was reasonable and consistent with the standard of care.
I am a labor and delivery registered nurse with more than 23 years of clinical nursing experience. I have also served as an assistant professor of nursing and as an educator providing obstetrical and labor and delivery nursing training to nurses across the country. Based on my review of the labor and delivery records, fetal heart tracings, flow sheets, and audit trail from the fetal monitoring system, it is my opinion that the nursing care in this case met the applicable standard of care. The patient was timely placed on external fetal monitoring, appropriate assessments were performed, meconium was documented, and the nursing team carried out appropriate interventions as the labor progressed. These included repositioning, oxygen administration, fluid bolus, and placement and readjustment of internal and external monitoring as needed. In my opinion, the fetal heart tracing remained Category 2 and never became Category 3. I do not find evidence of true bradycardia because fetal bradycardia requires a baseline below 110 beats per minute, lasting at least 10 minutes without recovery. I also do not view the alarm events by themselves as reliable proof of bradycardia because alarms can be triggered by movement and repositioning. The strip itself is the more reliable source for that assessment. I would also explain that reasonable labor and delivery nurses can interpret fetal monitoring strips differently and that inter-observer variation is well recognized. In my opinion, the nurses acted reasonably in their interpretation of the tracing, in acknowledging the alarms, and in communicating with the care team. There was good communication among the providers, and the standard of care did not require the nurses to go further up the chain of command or page the physician earlier than they did. Based on all of the available information, it is my opinion that the nursing judgment, interventions, communication, and documentation in this case were reasonable and consistent with the standard of care.
I am a board-certified pediatric neurologist and a professor of neurology with extensive clinical experience in the evaluation of newborn brain injury and hypoxic-ischemic encephalopathy. Based on my review of the medical records, laboratory data, and imaging studies in this case, it is my opinion that the child's brain injury did not occur during the labor and delivery period, but instead began prior to arrival at the hospital. One of the key reasons for that opinion involves the baby's condition at birth. The APGAR scores were recorded as 4, 6, and 7. In simple terms, APGAR scores are a quick way to assess how a newborn is doing immediately after delivery, including breathing, heart rate, and muscle tone. If a baby had experienced a severe, acute oxygen deprivation event during labor, we would expect much lower scores, a need for extensive resuscitation, or even a stillborn delivery. That was not the case here. I also considered the timing of the brain findings. A head ultrasound performed approximately 19 hours after birth showed significant brain swelling. In general, when an acute hypoxic event occurs during labor, it typically takes at least 24 hours for that level of swelling to develop. The fact that it was already present suggests that the injury process had started earlier. The laboratory findings are also important. While the baby was born with severe metabolic acidosis, that does not necessarily mean the injury happened during delivery. In my opinion, the acidosis reflects the baby's inability to clear acid that had already built up before birth, rather than a new injury occurring during labor. Putting all of this together, the clinical condition at birth, the timing of the imaging findings, and the laboratory data all support the conclusion that the hypoxic injury occurred hours before delivery and was not ongoing during the labor and delivery period itself.
I am a medical doctor who is board certified in diagnostic radiology with a subspecialty in neuroradiology. I have practiced in the field of pediatric neuroradiology for many years, and my opinions are held to a reasonable degree of medical certainty. My opinions in this case are based on my review of the imaging studies, including the head ultrasound performed shortly after birth and the MRI performed several days later, as well as my training, experience, and review of the medical records. In my opinion, the imaging findings identify a brain injury, but they do not support the conclusion that the injury occurred at the time of delivery. Instead, the imaging is most consistent with an injury that occurred prior to delivery. The head ultrasound performed within the first day of life shows findings of severe brain swelling and abnormal echogenicity. Based on the degree of swelling present at that early time point, it is my opinion that the injury more likely than not occurred approximately 2 to 4 days prior to the ultrasound. The MRI performed at 7 days of life demonstrates an evolving pattern of injury. The findings include abnormalities consistent with hypoxic-ischemic injury, as well as features suggesting seizure-related edema. This pattern is consistent with a more prolonged or earlier injury process rather than a single acute event at delivery. Based on these imaging findings and their evolution over time, it is my opinion that the injury occurred prior to delivery and is not attributable to events during the labor and delivery period at issue.
I am a medical doctor and a board-certified pathologist with subspecialty certification in pediatric pathology, and I serve as a professor of pathology. My work focuses on examining placental tissue to understand the timing and cause of fetal and neonatal injury. In this case, I reviewed the placental pathology, including microscopic slides and recuts of the placenta, along with the relevant medical records. Based on that review, and to a reasonable degree of medical certainty, my opinion is that the placenta shows high-grade fetal vascular malperfusion, a chronic condition affecting blood flow between the fetus and the placenta. This was not an acute event. The features I identified, including thrombi within placental vessels and abnormal villus development, indicate that this process was present for weeks or longer before delivery. These abnormalities reflect chronically reduced blood flow and oxygen delivery to the fetus, which is associated with neurologic injury and long-term impairment. The placenta was also relatively small for gestational age, which would further reduce the fetus's ability to tolerate additional stress. There is also evidence of a secondary inflammatory process, including both maternal and fetal inflammatory responses, which would have taken many hours to develop and further supports that this was not a sudden intrapartum event. Taken together, the pathology findings are consistent with a chronic intrauterine process that began well before labor and contributed to the baby's condition at birth.
I am a medical doctor and a board-certified neonatologist with subspecialty certification in neonatal perinatal medicine, and I am also a professor. To a reasonable degree of medical certainty, it is my opinion that this baby's neurologic injury was caused by a hypoxic-ischemic process that occurred before the mother arrived at the hospital, not by events during labor and delivery. Several findings support that opinion. The fetal monitoring showed decreased variability from the beginning and remained Category 2. The mother also later reported decreased fetal movement for about 2 weeks before delivery, which is consistent with an earlier process rather than a sudden intrapartum event. The laboratory data point in the same direction. The baby had elevated nucleated red blood cells, profound hypoglycemia, and abnormalities in coagulation studies, kidney function, and liver enzymes shortly after birth. In my opinion, those findings reflect a more prolonged or remote hypoxic insult, not a new acute injury during labor. The baby's condition at birth also matters. She had mildly depressed APGAR scores and required only brief resuscitation, which is not the typical presentation for a severe, sudden asphyxial event during delivery. Taken together, the fetal monitoring, maternal history, lab results, and newborn presentation support the conclusion that this was a remote hypoxic-ischemic injury predating labor.
The following is a high-level summary of the defense experts' opinions regarding damages. This position argues that the plaintiff's claims are significantly overstated, challenging everything from the child's life expectancy and the necessity of specific medical services to the financial methodologies used to calculate future costs. The defense contends that the child's life expectancy is significantly shorter than normal, based on peer-reviewed medical literature and comparison to similarly situated individuals with cerebral palsy and significant impairments in mobility and feeding. The opinion is that the child is likely to live approximately 18 more years. that reduced life expectancy directly limits the duration of future care. The defense argues the scope of future medical needs is excessive. While the child has permanent and significant impairments and requires ongoing care, the opinion is that portions of the life care plan include services that are not medically necessary, are too frequent, or are not reasonably supported by the child's condition. Some therapies are expected to be provided through the school system at no cost, and additional therapy outside of school would be limited and provided on an as-needed basis. The overall life care plan is also challenged as overstating both the scope of services and the cost of those services. Some items are said to be unsupported by the medical records, and some projected costs are considered inflated. The defense position is that appropriate case management would focus on cost-effective and efficient resources, which would significantly reduce the total projected cost of care. Even after those adjustments, the defense argues the claimed damages are overstated because the future costs were not properly reduced to present value. The opinion is that accepted financial methods, including appropriate discount rates and investment assumptions, result in a lower amount of money needed at the time of trial. A properly managed investment portfolio can be used to fund future care over time, rather than requiring the full projected amount upfront. Finally, the claimed economic losses are also challenged as overstated. The opinion is that the plaintiff's projections rely on assumptions and methodologies that do not fully align with accepted economic principles, when appropriate assumptions are applied for inflation, wage growth, and discounting. The resulting calculation of future losses is lower. Taken together, these opinions reflect the position that the overall damages claimed in this case are significantly overstated. Now it's time to review the main opinions of the EMR audit trail experts. The following is a high-level summary of what each expert's formal disclosure stated. One important note: although the defense disclosed an audit trail expert to refute plaintiff's expert, they did not call him as a witness during their case in chief. As a result, at trial, the jury only heard testimony from plaintiff's expert.
I am an attorney with an undergraduate degree in information systems, and I currently work as an EMR audit trail expert. I will explain to the jury what an audit trail is and how to read one, including audit trails from both electronic medical record systems used in this case. I will walk through how to interpret the data, including alarms and revision history. Using this data, I will reconstruct a timeline of care and documentation, showing not only what was charted, but when entries were created, modified, or deleted. I will also explain the modifications and deletions made by the labor and delivery nurse later in the afternoon, and how those actions appear in the audit trail. In addition, it is my opinion that audit trails do not contain all of the data stored within an electronic medical record system. They are a record of certain auditable actions, but additional data exists within the underlying database that may not appear in a standard audit trail report.
I am a biomedical informatician and professor specializing in electronic medical records and health information systems, including the design, implementation, and use of EMR data and audit trails. In this case, I will be testifying about how electronic medical record systems and audit trails function, including the main inpatient EMR system and the obstetrical monitoring system, and how those systems can vary in their configuration and use. I will also discuss my review of the EMR and audit trail data in this case, including the records and system audit logs that were produced. It is my opinion that the EMR and audit trail data are complete and consistent with applicable federal requirements. I also disagree with the opinions offered by the plaintiff's audit trail expert, and I intend to refute those opinions based on my understanding of how these systems are designed and how audit trail data should be interpreted. All of my opinions are offered to a reasonable degree of medical informatics certainty.
Now that we've reviewed the competing expert opinions from both the plaintiff and the defense, the focus shifts to the questions left for the jury to decide at the close of evidence. Was the fetal heart rate tracing so concerning by 9:42 a.m. that an expedited delivery was mandatory, or was the tracing a Category 2 that allowed for appropriate medical interventions prior to the 10:26 a.m. decision to perform a C-section? Plaintiff can argue that by 9:42 a.m., the midwife had already recognized the situation was so dire that she proactively obtained the mother's consent for a C-section. Their experts opined that every minute spent waiting after this point allowed the hypoxic-ischemic injury to worsen, The defense, however, would maintain that the midwife pre-consented high-risk patients for a C-section as a routine safety measure, not as an emergency trigger. Their experts opined that because the strip was a Category 2, the standard of care required exactly what the team did, escalating to a physician review and attempting intrauterine resuscitation, like oxygen and fluid boluses, while the doctor evaluated the patient in person. Another major issue in this case is, once the obstetrician made the decision to proceed with a C-section at 10:26 a.m., did the standard of care require that it be performed within 30 minutes? The timing of injury is also a crucial issue for the jury. Did the brain injury occur during the final minutes of labor due to a delay in delivery? Or, as the defense experts maintain, was the injury already set in stone hours before the patient ever arrived at the hospital? In medical malpractice cases, the standard of proof is not beyond a reasonable doubt, as in criminal cases. Instead, the jury is asked to decide whether the plaintiff has proven the case by a preponderance of the evidence, meaning it is more likely than not. The jury's analysis typically follows a step-by-step process. First, the jury must decide whether any of the healthcare providers failed to meet the applicable standard of care. If the answer is no, the case ends there, and the defendants are not liable. If the jury determines the care provided fell below the standard, the next step is causation. This is a separate question. A defendant can deviate from the standard of care, but if that deviation did not cause the injury, there is no liability. For example, in a case like this, a jury could conclude that the standard of care required a cesarean section be performed sooner, based on the facts of the case, but also agree with the defense position that the child's injury had already occurred before the mother arrived at the hospital. In that situation, the defendants would not be found liable. Only if the jury finds both breach of duty and causation do they move on to damages. If they make it to this final phase, the jury evaluates the plaintiff's damages. In this case, the plaintiff claims damages based on a lifetime of specialized needs, including 24-hour skilled nursing care, specialized equipment, home modifications, and therapies required for a child with spastic quadriplegia and cognitive impairments. Although the defense maintains that its clients are not liable, it still addresses damages in the alternative. The defense disputes the scope, cost, and calculation methods presented by the plaintiff, arguing that portions of the projected life care plan are excessive or not medically necessary. One of the main drivers of the large gap in the damages calculations is that the experts on each side project very different remaining life expectancies, with estimates that differ by decades. In any case like this, a jury must weigh the totality of the evidence. While the data from the EMR audit trail provides a high-tech forensic look at the timing of documentation, it is just one piece of a much larger mosaic. To reach a resolution, the jury must synthesize that digital footprint with the clinical medical records, the first-hand testimony of the parties involved, the observations of other fact witnesses who were in the room, and the competing interpretations provided by the medical experts. But the jury's job is not simply to decide what feels fair. They must apply the law as instructed by the court to the evidence they heard at trial. Only by weighing all of these pieces together, under the legal standards they are given, can they reach a legally supported outcome.
Well, that's the end of the video, and if you made it this far and you thought it was interesting, I'd love to get your feedback on 3 specific questions. First, what piece of evidence or argument do you think was most persuasive and helped plaintiff? And what piece of evidence or argument do you think was persuasive and most helped the defense? 2, was there something important that I left out of the MedCron that affected your understanding of the case and you wish I had discussed it or included it? And then 3, what did you think of the nurse changing her interpretation of the fetal monitoring strip 3 hours after the baby was born and the baby's outcome was known? Do you think that that mattered or that it did not matter? And do you think that that's the kind of evidence that would matter to a jury? Let me know in the comment section. Before we wrap up, there is one important thing that I need to mention. Unfortunately, I'm not able to share the outcome of the case. When I requested permission from my client to create this case study video, there were a few conditions, including that the results of the case remain confidential. So I'm going to go ahead and honor that, and I hope you can respect that. And, even without knowing the outcome, I hope this video was educational and that it clearly demonstrated why audit trails should be reviewed in every medical malpractice case. And I do have one small request. If you can, please avoid mentioning the missing outcome in the comment section, because I'd like viewers to be able to approach this video without knowing that influencing their thinking as they watch it. Thank you for understanding. That's it for this video. Hopefully I'll see you in the next one. This is What the Chart Won't Say, where we follow the data and let the facts speak for themselves. Bye.